All right, the next paper on a similar topic, outcomes of median arcuate ligament release and celiac plexus neurolysis in 72 patients with median arcuate ligament syndrome from University of Washington.
My name is Grafton Kirk, and I am a second-year medical student at the University of Washington. Thank you for the privilege of the podium. I have nothing to disclose. Median arcuate ligament compression of the celiac trunk was first reported in 1917 and was first described as postprandial epigastric pain with celiac stenosis in 1963. The first surgical reports on median arcuate ligament syndrome, or MALS, was in 1960s by Dunbar, earning MALS the eponym Dunbar syndrome. 13 of these 15 patients who underwent median arcuate ligament release reported symptom improvement in this series. Despite the decades since MALS was first described, the etiology of MALS has been the source of some controversy, with some questioning whether MALS is a true disease. This is due in part from the observation that up to 24% of the population may have compression of the celiac axis from the median arcuate ligament. However, less than 1% of these are symptomatic. This is further supported by the lack of strong results showing symptom improvement after revascularization techniques, including stenting, and the presence of high collateralization in symptomatic patients. More recently, the research has supported that MALS is less a disease characterized by ischemia, but rather celiac ganglion allodynia and dysautonomia. To understand MALS, it's important to discuss the underlying anatomy. The median arcuate ligament joins the left and right crura of the diaphragm, arching over the aortic hiatus around T12 and L1. Just below this is the celiac trunk, which is compressed in MALS. Lying just above the celiac trunk is the celiac ganglion. As you can see from the figure, compression of the celiac trunk by the median arcuate ligament will also compress the celiac ganglion. There are many proposed diagnostic modalities for MALS, including gastric exercise tonometry and provocative mesenteric angiography. However, there's no standard diagnostic algorithm for MALS. The common clinical presentation of MALS includes symptoms of postprandial epigastric pain, leading to food fear and unintentional weight loss, which can be severe enough to require nasogastric feeds or TPN. Additionally, patients may present with epigastric tenderness, nausea, bloating, vomiting, and pain with exercise. Diagnostic imaging modalities include duplex ultrasonography with CT angiography or magnetic resonance angiography with respiratory variation. Relief from a celiac plexus block can be indicative of MALS. MALS typically demonstrates a peak systolic velocity of greater than 200 centimeters per second in the celiac artery on mesenteric duplex ultrasound. This is greater with expiration due to increased compression from the median arcuate ligament. Here on axial CT, you can appreciate the classic J-hook appearance of celiac artery compression. Celiac compression is exacerbated on forced expiration due to contraction of accessory expiratory muscles that raise the aorta superiorly into the median arcuate ligament. This was a single institution retrospective study. Data was sourced through prospectively collected pre and postoperative SF36 quality of life questionnaires and retrospective chart review. All cases were completed by a single surgeon who performed open median arcuate ligament release with celiac ganglionectomy. We established 3 separate comparisons for this study. The first sought to determine the association between the presence of pre-surgical classic symptoms and/or imaging findings with post-surgical quality of life improvements. Positive signs and symptoms were defined as 3 of the 5 of the most common symptoms: epigastric pain, postprandial pain, nausea, unintentional weight loss, and food fear, or the presence of both epigastric pain and postprandial pain. Positive imaging findings were defined as a celiac artery peak systolic velocity greater than 200 centimeters per second, or evidence of stenosis on CTA or MRA. The second comparison sought to determine if pre-op psychiatric diagnosis was associated with a change in quality of life improvement following surgery. Similarly, we stratified the ages of subjects to observe any associations between age and change in quality of life improvement following surgery in our final comparison. The primary outcome of this study was the degree of improvement in SF36 scores after surgery. We weighted each subsection equally and calculated the change in overall score. We looked at the differences between groups using percent change after surgery. And here is an example from a patient in the series demonstrating SF36 scores before and 6 months following surgery. Now onto our results. 37% of the patients referred for MALS received surgery at the time of analysis. Of these, the average age was 37, and we observed a 5-to-1 female to male predominance, which reflects a similar ratio to that found in the literature of 4-to-1. Interestingly, 72% of these patients carried a psychiatric diagnosis on their medical record. 25% were diagnosed with POTS, 20% with Ehlers-Danlos syndrome, and 10% with mast cell activation syndrome. In our first comparison, we compared the post-surgical outcomes of patients with both the classic signs and symptoms of MALS and characteristic imaging findings against those with characteristic imaging findings alone. There were 31 and 11 subjects, respectively, with both pre- and post-surgical quality of life questionnaires available for analysis. Patients with classic symptoms without classic imaging findings were excluded as there was just one subject with complete quality of life data. We observed that those with imaging findings without meeting symptom criteria experienced an average of a 35% increase in quality of life. However, those with both imaging findings and the classic symptoms experienced more than a doubling of quality of life score, with SF36 scores increasing by over 125%. This reached a significant difference between the two groups. Here's the same data showing the positive imaging and symptoms group in blue and the positive imaging alone group in orange. The positive symptoms and imaging group experienced a significant increase in quality of life, whereas the positive imaging alone group did not reach a statistically significant improvement. It is also worth noting that the positive symptom and imaging group began with a significantly lower quality of life score on average than the positive imaging alone group. Next, we compared the 30 subjects with a psychiatric diagnosis to the 13 subjects without. In this comparison, we observed no significant difference in quality of life score improvement between the groups. For our final comparison, we stratified patients by age, as shown here. An ANOVA analysis did not demonstrate that one of these groups differed from the others in terms of quality of life improvement. Of note, the 20 to 29 and 30 to 49 groups appeared to experience greater improvements than the under 20 and the 50 and older groups. In conclusion, we found that a large proportion of patients who received surgery in the study had a prior psychiatric diagnosis, and the classic MALS symptoms we defined in this study were a strong indicator of post-surgical quality of life improvement, whereas imaging findings alone were not as reliable of a predicting factor. Lastly, age and psychiatric diagnosis did not show a strong correlation with post-surgical quality of life improvement. Thank you, and I'm happy to respond to any questions.
Nice presentation. I have a question about the patients who have imaging findings but no symptoms. So why are we operating on those patients, and how can we expect quality of life improvement if they have no symptoms to begin with?
That's a good question. Thank you. So the patients who fit into that category may have had symptoms, but they may not have had the classic symptoms as we defined in the study.
I see.
We tried to use that determination to find the most classic symptoms that are associated with MALS in the literature.
I see. So it's not that they're asymptomatic, it's that they're not typically symptomatic.
That's correct.
Okay.
Yeah, and just to add to a quick point, since Ben's not here, all of his patients undergo a preoperative celiac plexus block, and he pretty much requires that they have a response to that. There's obviously a placebo effect concern with that, but if they don't have a response to celiac plexus block, he does not do a median arcuate ligament release. He does not operate on asymptomatic patients.
I was going to say, I could answer that question. I wasn't even involved in this study. They got surgery because they came in and they said, yes, I had a good response, and even though you counseled them for that reason. But I missed a little bit of the last discussion, and I'm shocked, like, more people have questions about MALS than the FEVARs, but when is this not going to be a vascular surgery issue? I would like to ask Dr. Garg if they could publish these, if we could have these put in like some other journal, like internal medicine, family medicine, if you'll give them a pass, because or GI, because I do feel that we still see all of these patients, and we are still discussing with them that they need celiac plexus blocks, they need a celiac plexus dissection, like we heard about in the other paper. But when is this something that I don't know that vascular surgeons are going to be managing all the time, or have to even see at some point?
I can help Graf out here. Thanks, Graf.
Existential question.
Thank you.
Graf did a fantastic job. You know, Misty, that's a tough question, but I think once other people get comfortable operating in this region is when you're going to probably not have these patients be a vascular surgery problem. Because even if you do it laparoscopically, there's been patients in this series that have had laparoscopic releases, and when Ben's done these cases, the celiac ganglion hasn't been touched. So I think that once you get people that are comfortable operating on this, Dr. Finley described robotic surgery. The majority of the time, most laparoscopic surgeons are just going to release the arcuate ligament, and they're not going to, get onto the artery and skeletonize it. So I think that's when it doesn't become a vascular surgery problem. One of the real benefits of this and doing it open is that you have the opportunity, and all of our trainees, our senior trainees graduating with 20 of these cases, but you're operating on the supraceliac aorta and you're skeletonizing every branch. So it's a real great opportunity for them to do that. And the results have been pretty solid. And this is 4 years, 72 patients. He's over 100 now. So these people come, but it's a very selective process. As Jake said, the celiac plexus block is the big differentiator into doing these procedures. But Graf, great job.
Thank you. And I'll just add to that, I think that one of the takeaways from this study could be just identifying MALS patients a little bit better through symptoms. So.
I don't think this is ever not going to be a vascular surgery problem, just for the record. Anytime you see stenosis in a vessel, vascular surgery is going to always get called, whether it's MALS or whatever it is. It's just the way it is. So we can reject this paper for the journal, but I'm not going to.
Real quick, yeah.
Cassius Char, Yale New Haven. So I see Dr. Humphrey's kind of frustration sometimes with those patients, and I do have sometimes the similar frustration. But I do think in addition to just the open exposures or whatever proximity, I mean, we deal as vascular surgeon with a lot of compression syndromes, whether it's thoracic outlet, May Turner, in other places, and it's going to be in our kind of expertise. And I see actually a great opportunity, especially with the prior presentation, with robotic surgery being involved in that. And I think we should start adopting that, maybe not you and I, Misty, but maybe the students who are, and the residents, general surgery residents that are interested in vascular surgery. I have one fast question for you. Can you tell us a little bit more about the surgeries that were done? Were there's all laparoscopic? Were there any robotic surgery performed? Was there any revascularization? I know revascularization is not the mainstay, but do you guys do it at all?
Thank you for your question. They were all open, and I don't believe we had any re-intervention in any of these patients, or any endovascular intervention.
Thank you.
So great talks generate a lot of great discussion, and I'm sorry that we don't have time for more questions.
I think we need a MALS special session next year.
But I will say, I don't think vascular surgeons will ever be divorced from this pathology. But as the next person's coming up, I will say, specifically, it just shows how great diagnosticians vascular surgeons are. Because the reason why the general surgeons or whoever, if it's not a vascular surgeon doing the release, the general surgeon wants the vascular surgeon to opine about the pathology. And is it true? Is it not? Should I do the operation? And they rely on us for that.